Everybody, Dr. Stahlman here. It's Friday, therefore it must be the doctor is in live with TOA. I hope everybody's well. This is such a beautiful time of the year. Unfortunately, circumstances are rather strange, but fortunately, because we've been forced to be at home, I've actually found that I've enjoyed the spring more. I've been able to get out and walk around in the nature and enjoy the red buds and the dogwoods and all the blooming plants. So I'll take it. It's not ideal, but I'll take it. I need to check one thing to make sure this thing is running. Sorry. Okay, anyway, so as you can see, I'm in the home studio today. I'm not in the office. I was actually doing telemedicine visits this morning, and I wanted to remind everybody that TOA now offers telemedicine visits. Almost all the doctors are doing them, and basically it's an online virtual clinic visit. So if you don't want to come into the office, if you just have routine follow-up, if you are a person at risk, we can offer you a telemedicine visit so you can do that at home at your convenience. It's simple, it's straightforward. There's a couple of steps to have to go through to set it up. The information is on our website, www.toa.com. And I think most patients that I've dealt with have had a really good experience with it. I'm hopeful that we can continue on with a form of telemedicine after the whole virus thing is over with. As always with the Doctors In episodes, I want to remind you that while I am an orthopedic surgeon, I'm not your orthopedic surgeon, and so everything we talk about today is really for educational and entertainment purposes, not medical advice. If you need help with musculoskeletal condition, please contact us at TOA and we can find somebody to give you some help. I thought today we'd go back to the bread and butter of what these episodes were all about and what they were founded on, which is clinical information. We've talked a lot over the last few weeks about the virus. We've talked a lot about aspects of surrounding the virus. I'd like to get back to a little bit of orthopedic medicine. And today I thought a good topic would be to talk about something that affects a number of people and is quite prevalent in my practice, and that's osteoporosis, compression fractures, and treatments of compression fracture. So today's episode is going to be a little bit of a basic science lecture, an anatomy lecture, and then an epidemiology lecture about what osteoporosis is, how it affects us, and why it's so important. So first, the basic science. Bones in your body are living structures. They have cells, they have different structural properties, but they are living and can change as the situation changes in our lives. The primary mineral in bone is calcium, and calcium is obtained to build bone from our diet primarily. This is an important part of osteoporosis management and treatment. Bones are made up of two types of cells, basically. There's osteoblasts, which are cells that grow bone, and osteoclasts, which are cells that dissolve bone. And normal bone health is essentially a balance of osteoblast creation of bone and osteoclast absorption of bone. Osteoporosis is a disease where that balance is out of whack, and so we see more loss of bone than building of bone. And that can come about in several ways we'll talk about in a second. If we think about the thigh bone, that's probably the best one to think about, called the femur. The thigh bone has essentially three sections in it. The main part of the bone, the shaft of the bone in the middle of your thigh, is called the diaphysis, and it's essentially a big thick tube the bone is very densely packed and it's very rigid. That's called cortical bone, and that bone is very strong. At either end of the femur bone are areas where the joints are. So in the upper part is where the hip is, in the lower part is where the knee is. And the structure in the ends of the bones is different than the strong tubular cortical bone. It's called cancellous bone, and basically it looks more spongy. If you cut the upper part or the lower part of the femur open, what we see is a hard, bony shell. It's almost like frosting on a donut, with a more spongy-like looking center. And that spongy-like center is bone, and in and of itself is fairly rigid, but it's very porous. And the reason why the bones are built that way is a couple of reasons. And the most important is bone naturally changes depending on the forces applied to it. That's called Wolff's Law. And in Wolff's Law, the more pressure or compression on bone cells, the stronger that area of bone becomes. And so in the upper part of the leg, for example, around the hip, the inside curve of the where the ball attaches to the thigh bone is stronger because it has to resist more force than the outside is. And that changes as forces are applied to the bone. So not everywhere in the bone is the density of the bone the same. The second part of why bone is spongy like that is that's where the bone marrow is. Bone marrow is where your body produces red blood cells. And so that area is packed full of these cell-producing cells, and that's where your body gets its red blood cells. So we need somewhere to create red blood cells, and that comes from your bone. So you've got these hard-surfaced, somewhat spongy, flexible ends of the bone, and then the center of the bone, the mid portion of your thigh bone, is a more rigid tube. And all of that works together to allow us to encounter the world. Essentially, you and your body and gravity interacting with the earth puts forces on the bone in different areas. And again, by Wolff's Law, the areas where bone sees more force, the bone becomes more dense or strong. The area where bone sees less force, it doesn't need to be as strong. That also plays into osteoporosis. So we've got the cells, osteoclasts and osteoblasts. We've got the types of bone, cancellous bone, which is the spongy type of bone at the ends, and the rigid type of bone called cortical bone. So what is osteoporosis? Osteoporosis is a disease of bone metabolism, and basically what that means is it's an abnormality of how bone is formed and modifies over time. Essentially, in simple terms, it's a disease that leads to more brittle bone. Now, there are a variety of reasons why people develop osteoporosis. Women tend to get it more than men, but men can get osteoporosis as well. The primary reason why people develop osteoporosis is genetics. Their family members preceding them have a tendency to develop osteoporosis, and that gets passed down. There are some diseases that can lead to osteoporosis. Problems with your parathyroid hormone, which is one of your calcium regulating organs, can lead to not enough calcium in the bones and lead to weakness of the bones. There's a number of metabolic or endocrine problems that can lead to imbalance in how much calcium is deposited or taken away from the bone. And then there are medications and other circumstances that can lead to developing an imbalance in osteoblast and osteoclast function. Diseases where people are not able to get up and move around. They don't bear weight very much on their bones. That can be simple aging. It can be infirmity related to a variety of other conditions. but it's the actual inactivity, the non-weight-bearing activity, that can lead to weakening of the bone. In addition, medications like Dilantin or phenytoin, which is an anti-seizure medicine, can lead to weakening of the bone. Chronic steroid use can lead to weakening of the bone. And these work in different ways. Some of these processes affect the osteoblast function, which means that bone doesn't get formed as quickly as it gets dissolved away. And some affect the osteoclast function, which means that the bone is getting more quickly absorbed than can be built back up. And sometimes it's both. Treatments for osteoporosis are essentially geared toward trying to make that balance reappear. Okay? First off, we have to figure out, is it simply a genetic osteoporosis, or is there other disease that can be changed that might affect this, or medications? The reason why osteoporosis is so important is that as the bone weakens, the likelihood of developing a fracture with less and less and less trauma goes up. And as you can imagine, if somebody breaks their hip or breaks their spine or breaks their wrist, it can mean a big impact on their lifestyle, as well as their potential for things like morbidity or complications or even death. I mentioned before that women tend to have osteoporosis more than men. One of the big components of this balance of osteoblast and osteoclast function has to do with estrogen levels. Estrogen is a female hormone, although men have estrogen too. Females have a lot more estrogen, and that goes along with their reproductive cycle. As women get past having had children or get past their menopause, their body shuts down the production of estrogen. So the estrogen level drops substantially. That means that the osteoblast-osteoclast balance gets thrown off, and we actually see weakening of bone in those people who have a propensity, a genetic predisposition for developing osteoporosis. That's where many years ago, we gave a lot of women estrogen hormone replacement to try to restore some of that balance. Now, unfortunately, it's kind of like robbing Peter to pay Paul. There are consequences to giving somebody estrogen, and that can be things like increasing the risk of cervical or breast cancer. So there's a balance that has to be struck with regard to utilizing these medications. What's the typical look of somebody who is potentially at risk of osteoporosis? Well, it's actually fairly easy to identify. Small frame, tiny, white and Asian females have a much higher risk of developing osteoporosis than do African American females or males. We're not sure why that is, but it clearly has something to do with genetics. In addition, women who have had pregnancies, particularly multiple pregnancies, and especially if they have breastfed for an extended period of time, will develop periods of osteoporosis or weakening of the bone because their calcium levels drop so much during those episodes. And then women who develop menopause, when they develop menopause, whether that's naturally or whether it's when they've had a hysterectomy and their ovaries removed and we've surgically created a menopause, then we start seeing a drop off on the estrogen. We'll talk about women because that's the vast majority of people who have osteoporosis. Women who have osteoporosis also commonly aren't very active. And so that's an important factor. I'm sure a lot of people have heard about treatment or management of osteoporosis, and probably the first step for a primary doctor to treat osteoporosis is calcium and vitamin D supplements. The purpose of the calcium is to try to restore the mineral deposit in the bone. your body needs calcium. It uses it a lot for nerve conduction and muscle function. Body's got to get calcium from somewhere because it doesn't produce it itself. And so it either gets it from your diet intake or it takes it from itself. And the biggest storage facility of calcium in your body is your bone. So if your body's not absorbing calcium through your diet, it gets calcium from your bone. And so bone loss is always going on to try to maintain that calcium balance. The trouble is you just can't take calcium orally by mouth and have it successfully absorb into your body. Calcium needs vitamin D in order to absorb the calcium. Now, vitamin D is created by your body by the exposure to sunlight. So when we were outside all the time and working in the yard or in the farm, and people didn't think about sunblock and sun exposure related to cancer risk, people had much higher levels of vitamin D in their body because the sun exposure helps us to produce vitamin D. What we found these days, because we're cautious about sun exposure, because there is a risk of skin cancer, that people's vitamin D levels are lower. And in some cases, we found people with profound vitamin D loss. And so that's a big area of interest to the endocrinologists, the metabolism doctors, the hormone doctors, because we found that low vitamin D can affect lots of body parts. So when somebody receives calcium recommendations from their doctor, they should be receiving vitamin D supplementation as well. Unfortunately, giving somebody calcium and vitamin D is not something that really will treat osteoporosis or low bone density. What it will do is it will give your body an alternate source of calcium rather than the bones to do its job. So we're really treading water by giving people calcium and vitamin D. It's important because we want to reduce the amount of bone loss, but it is not really able to build up bone density by itself. We talked about the importance of when bone density goes down, the fracture risk goes up. Why is that important? Well, it's been shown that fractures, particularly of the hip or of the spine, substantially increase people's morbidity and mortality. What I mean by that is it can substantially affect their general health and their lifespan. People who break their hip with minor trauma, even if we fix it, are at a much higher risk of becoming sedentary or dying within a year of their hip fracture than those folks who don't break their hip. As we get older, the risk of hip fracture in particular goes up because our balance goes away, our muscle strength goes away, our bone density decreases, and so it's much easier to stumble, fall, and fracture something as we get older. So the point of osteoporosis management is identify those people who are at risk, measure their bone density with a bone density test early, look at their history and their family history, and try to prevent osteoporosis from getting hold of them. The trouble with osteoporosis is it's a painless, asymptomatic, or without symptoms disease. People can develop osteoporosis and have it for years and years and years and never know it unless they either got a bone density test or, more likely, is they show up in the emergency room after stumbling in their garden and have a broken hip or a broken spine. And so it really is a silent disease. So we have to think ahead of the game, and the people we really need to think about treating are not the people that already have osteoporosis, but those people who are at risk. So what are the treatments for osteoporosis? Well, it's really to try to balance that osteoblast, osteoclast activity. And there are a variety of chemicals that are out there that can do that to some degree. As I said before, calcium and vitamin D aren't a cure. They are a supplement to help reduce bone loss. So the medications can be a useful tool. There's a variety of different types of medications. They work in different ways. All of them do not make normal bone density, and none of them are risk-free. Some have been implicated with increasing bone density, but then increasing the risk of fracture in another part of the body, such as the jaw or the thigh bone. So you really have to talk with your doctor, whether it's your primary doctor, your OBGYN doctor, a rheumatologist, or an endocrinologist about this to really understand the pluses and minuses of each of these treatments. There's not one that's necessarily better than another, but there's typically a protocol of starting with one and then working to the other. Again, the ideal situation is to prevent osteoporosis from showing up rather than trying to treat it. A mainstay of trying to manage good bone health is weight-bearing exercise. This goes back to the Wolff's Law description. When bone is used, when bone sees force, when you bear weight through your bones, it can get stronger. In addition, you can see bone lose less density by doing those things. So the standing, walking, strength training, flexibility, all working on putting gravity and body weight through your bones can be very helpful in helping to manage bone metabolism and bone density. I'm not very familiar with it, but there's a company called OsteoStrong, which is a specific style of intervention with osteoporosis that uses weight-bearing and vibratory maneuvers to help stimulate bone cell growth. So osteoblast function, trying to reduce osteoclast function. It's got a lot of followers, and I think it's a very good additional opportunity, including supplements, diet, and regular exercise to try to help people with bone density issues. I forgot to tell you the designations of osteoporosis. So there's bone density has kind of 4 categories. One is normal. One is called osteopenia, which means that the density of the bone is 1 standard deviation lower than the expected average. Osteoporosis, which is where the bone density is at least 2.5 times lower than, it's 2.5 standard deviations lower than the expected average. And then the last is what's called severe osteoporosis, and that's essentially osteoporosis with a fracture. So somebody who's broken their wrist or their spine or their pelvis or their hips. So I'm a spine surgeon, and osteoporosis affects a lot of my patients, and the spine is a very common place to see fractures. Why is that? Well, the vertebrae, the bones in the spine, are all cancellous bone. They have that tough cortical hard shell on the outside and that spongy spiderweb type bone on the inside. It's the cancellous bone that gets weaker and weaker and weaker with osteoporosis. And because the spine is a major support system for your entire body weight, you can see that the spine can bear a lot of potential for trauma. The trouble with osteoporosis and compression fractures, or fractures of the spine related to osteoporosis, is it can create pain, very painful for very long. It can create deformity of the spine. Actually, every time a bone crunches down, think of a styrofoam block that's getting crunched down, that's kind of what we look at it as. The spine can change in alignment. And one of the big factors that can occur is as the spine changes in alignment, it can increase the risk of either fracturing bones, or it can compromise how much you can fill your lungs up with oxygen. And so you'll see the little teeny old ladies who become very hunched over and curled over, and that's related typically because of the collapse of the spine related to osteoporosis associated fractures. Forever, we had no treatment for that. We could put people in a brace, we could give them pain medicine, we would allow it to heal, but it wasn't terribly satisfying, because many times these patients are very, very, very uncomfortable for a long period of time. About 15 years ago, techniques were developed, and the one that I use that I'm a big fan of is a technique called Kyphoplasty. And this is a minimally invasive surgical procedure where, using a special x-ray machine so we can see where we're going in real time, we insert a small tube through the skin into the bone. The tube's less than the size of a drinking straw, into the bone, and then use that channel to create a void within the bone, kind of tamp out a little pocket in the bone, and then fill that bone up with an epoxy glue. It happens to be called PMMA, polymethyl methacrylate, and it's an epoxy two-part material that we mix. It's a solid and a liquid that's mixed together, makes kind of a slurry, and then it hardens up in about 10 minutes. It's the stuff we actually glue hip replacements in with. And what we've done is we fill up that bone, all the nooks and crannies of that cancellous bone in the broken one, and fill it up, and it hardens and becomes rigid. And that stops those little pieces from moving around, adds more support, and is amazing at trying to help people decrease the back pain that's coming from a recent compression fracture. Now, the trouble with compression fractures is they can develop with very little trauma. I've had patients who simply bent over to tie their shoes, or rolled over in bed, or picked something up out of their car trunk, sneezed or coughed, and have had a fracture in their spine. Certainly a fall is something that can lead to fracture. My mother-in-law developed pneumonia, and she coughed, and once the pneumonia cleared, she had this horrible back pain, and what we found out was she had a compression fracture, and it wasn't getting better, and so we ultimately did kyphoplasty for her, and it was an amazing experience. She came in, we did the procedure, and she had immediate, near complete relief of her pain and went home the next day. These days, we actually do it as an outpatient. You don't even have to stay in the hospital. So for those patients who have had a compression fracture recently, and that's the key, the treatment with kyphoplasty can only really be effective for those fractures that are recent, that have not healed yet. Once it's healed, we can't really do anything about it. But those people who have had a recent fracture, who have severe pain, and if they're healthy enough and the bone condition is good enough to undergo surgery, kyphoplasty can be a very useful tool in decreasing or eliminating the pain from the fracture and letting them get on with their life so they can avoid the morbidity of not being able to get around, the risk of developing a pneumonia or a blood clot or bed sores, things like that, because they can't get up because it hurts so much. So today we've talked a lot about bone metabolism. We've talked about how bone is created using osteoblasts and how bone is modified or dissolved away using osteoclasts, and good healthy bone is a balance of those two systems. We've talked about Wolff's Law, which means bone changes depending on how much stress or force it sees. It gets stronger under stress. We've talked about osteoporosis, some of the signs of osteoporosis, the type of person we see who develops osteoporosis and why, such as genetics, medications, and certain diseases. And we've also talked about osteoporosis with regard to the risk of fracture and what that means. It's not just a broken bone. It can be just a nuisance, but many times fractures like these actually can lead to increased morbidity and increased mortality in patients, because this often affects an older population. And then lastly, we talked about an area of my interest, which is kyphoplasty, to try to treat compression fractures of the spine. So I hope this has been helpful to you. I think we're about done now. I do want to let everybody know that while people are getting antsy and stir crazy, being stuck, distancing from one another, and there's a lot of stories out there which we don't all know the truth of regarding, is it over? Is it just beginning? How long are we going to need to do this? The scientists are making their best educated estimation about time for restriction and hope that we can minimize the impact of this disease. It's been hard on everybody. I shout out to my employees who we've had to furlough. We are looking forward to having you back in the office and having full running operations. And I'm sorry we had to do that, but I want you to understand that it's not because we don't want you. We do. We have to keep the business running, and so I shout out to you for being tough, and I look forward to seeing you back in the office soon. Anyway, so that's it for today. Not sure what the topic will be next time, but please, if you have interests or topics you'd like to discuss, leave it in the comments. If you have a need for orthopedic care, TOA is open. Some of our smaller offices have been shuttered temporarily and combined with some of our larger offices, but we are open and seeing patients. The restrictions are starting to ease a little bit, although we're not still able to perform elective surgery at this point. The governor's restriction will run out at this point, the end of April, but it could get extended. And also I want to remind you that telemedicine is now available. Go to the website, toa.com, click on the link to the telemedicine page, and can give you instructions about how to approach that. We're able to use telemedicine for all the payers, Medicare included. Basically, it's just like an office visit, except it's remote. There are a few disadvantages to it. For example, I can't lay hands on people. I can't get an immediate x-ray, but it's a very useful tool to try to keep people out of the office environment to protect them. So utilize that if you'd like. My patients have really enjoyed it. I've really enjoyed it. Anyway, until next time, I hope you all stay healthy. Go out there and enjoy this beautiful spring weather before it turns blazing hot, and go out there and live your best life.